Practical conduct of anesthesia for laser resection of tracheal stenosis. Here is an image of a severe tracheal stenosis requiring surgery. This image shows a radiological reconstruction in 3 dimensions. You see the tracheal stenosis near the top of the trachea. Here we see laser incisions at various positions radially around the stricture. This is a nice open trachea, and here's a summary image of results of treatment. Here is an example of a suspension laryngoscope. Note the plastic tube with the Luer lock connector at the end. But note that suspension laryngoscopes come in all sorts of shapes and sizes, and you may meet some with non-standard connections that you may have to work with. Now we will begin a detailed consideration of the use of the jet ventilator, the most important component of which is this metal device called a Sander's injector. The Sander's injector is supplied by green oxygen hose coming from the wall supply at 415 kilopascals or 4 atmospheres pressure. Leaving the Sander's injector is a clear plastic piping which ends in a male Luer lock. If you're going to presume to manage these very challenging cases, you must be intimately familiar with the use of the jet ventilator. This portion of the jet ventilator, immediately prior to the Sander's injector, is a pressure reducing valve and pressure gauge for modification of inflation pressures. Your ability to have maximum control over pressures liberated by the Sander's injector is to hold the Sander's injector in a precise fashion. There is a silver hook on the jet ventilator into which the index finger of the dominant hand should be placed. And this, as you hold the Sander's jet injector in the palm of your hand, this brings the thumb into opposition on the pink lever that activates flow. With wear and tear over the months, the plastic pipe where it meets the Sander's injector can sometimes develop cracks which cause a leak. These can sometimes appear actually during a case and may well need emergency repairs on the fly while a case is being done. Orange tape can be most useful to temporarily prevent the leak in these situations. Here is a selection of the surgical instruments that you may see in use during a typical case for laser resection of a tracheal stenosis. Note, of course, that different surgeons have different preferences, and so you must quickly develop a familiarity with the instruments that your surgeon will use. Note here the very long forceps for holding the mitomicin soaked pledget in position. Here is an image of the surgeon using the suspension laryngoscope. It is supported by a metal arm placed on the Mayo table and holds the suspension laryngoscope in place so the surgeon has his hands free. You see an image of the glottic opening, and this image confirms that the suspension laryngoscope and the trachea are exactly collinear, and now the suspension laryngoscope is safe for use for ventilating the patient. to induction, all monitoring leads and fluid administration sets are led off the operating table to the patient's left, because we will be turning the table towards the right. Perform an analysis of the likelihood of rapid arterial desaturation. Thorough pre-oxygenation of the patient is performed between 3 and 6 minutes, depending on the results of your perception of their risks for desaturation. After induction of general anesthesia, do a test of mask ventilation. When you are confident of your ability to mask ventilate the patient, a full paralyzing dose of a non-depolarizing muscle relaxant such as rocuronium is administered. The patient is ventilated with 100% oxygen and 1 Mach of volatile agent until the onset of full paralysis. Then, with reference to the anesthesiologist's position at the head of the bed being 6 o'clock in a clock face, the operating table is turned 90 degrees counterclockwise to the 3 o'clock position on the clock face. And by doing this, you're delivering the head of the patient to the care of the surgeon, who is sitting in that position waiting to perform the surgery. The anesthesia machine will not be in use until the end of the procedure, and so gas flow rates through the circuit are returned to basal levels and the vaporizer is now switched off. The surgeon will extend the patient's head on their neck so that the neck is extended, the mouth pops open, and a suspension laryngoscope is inserted. This suspension laryngoscope will be suspended from a Mayo stand and which is placed directly over the patient's chest. When the suspension laryngoscope reveals an excellent view of the larynx and the glottic opening, the support of the suspension laryngoscope is locked in position, and this maintains the long axis of the suspension laryngoscope collinear with the long axis of the trachea. This is essential for jet ventilation to be effective. So, I guess I've given the game away. We will be using jet ventilation for this procedure. The suspension laryngoscope and the other surgical instruments can put pressure on the delicate laryngeal and airway structures. And so, both vocal cord and false cord swelling is possible post-op. In an attempt to prevent this, most patients will receive a dose of 8 to 12 milligrams of IV dexamethasone shortly after induction of anesthesia and before the injury to them is done by pressure from the instruments. The jet ventilator tubing with its male Luer lock connector is now connected to the female connector, which allows for jet ventilation. This is a female connector on the suspension laryngoscope. The jet exits from the distal tip of the suspension laryngoscope. When the surgeon is happy with the position of the suspension laryngoscope, inform them that you intend to do a test of jet ventilation. When they agree that it is safe to continue, place your left hand on the patient's chest and activate the jet ventilator rhythmically to ensure both steady rise and fall of the patient's chest. Your left hand may be the most important monitor you have in this situation. You're monitoring movement of the chest, both upwards and downwards. The surgeon places a camera within the body of the suspension laryngoscope, visualizing the subglottic region. Beyond the vocal cords in the trachea, in the distance, the subglottic stenosis is visualized. At this point, the surgeon will want to use laser therapy on the subglottic stenosis. Laser safety precautions are initiated with a warning sign of laser in use placed clearly outside the operating room to warn people entering the room. Protective glasses must be worn by everybody in the room, and the patient's eyes are also protected by dampened dressings placed over their eyes. In this airway technique, it is of course impossible to control inspired oxygen concentration. But the absence of any endotracheal tube in the airway means there is no risk of airway fire. There's nothing combustible in the airway. Establish rhythmic jet ventilation of the patient to maintain effective oxygenation and hopefully reasonably reliable elimination of carbon dioxide. But not knowing the tidal volumes, this really is once again more art than science. Activation of the jet. will cause movement of the larynx and the trachea, and so ventilation must be suspended when the surgeon is about to activate the laser, as most surgeons prefer not to have a moving target. Ventilation will also be suspended during balloon dilatation of the stricture and during application of mitomicin C pledgets. Prior to holding ventilation, it's a good idea to have an uninterrupted period of good ventilation to minimize arterial desaturation during these intervals of suspended ventilation. Be aware that arterial carbon dioxide tension will increase insidiously during these apneic intervals. This procedure usually takes less than about 40 minutes, maybe entire time in the room approximately an hour. Towards the end, you may notice the patient initiating spontaneous ventilatory efforts, or the surgeon may report that the patient is swallowing. The ventilatory efforts may be an indication of a rising or a high CO2 level. The end of the procedure is usually imminent, so I try hard to avoid supplemental doses of rocuronium, and if the surgeon is worried that the patient is light because they're swallowing, I use small doses of propofol. When the surgery is finished, the surgeon removes all the instruments from the patient's mouth, including the suspension laryngoscope. An oral airway is placed in the patient's mouth, and the anesthesia mask is connected to the breathing circuit and used to provide mask ventilation. It's a good idea to suction the mouth and remove any saliva just before you pop in the oral airway. At the end of the procedure, if I'm working alone, I have the head of the bed turned back clockwise to the 90 degree position, with the head of the patient back at the 6 o'clock position on the clock face. The patient's head is near the anesthesia machine. If I have an assistant with me, I don't do this. I leave the operating table where it is, and I have my assistant go to the head of the operating table with a face mask and the breathing circuit connected, and we will do mask ventilation. The anesthesia machine flow meters are now set to 6 litres of 100% oxygen, and these are administered to the patient through a well-applied anesthesia face mask. If the patient is exhibiting spontaneous breathing or swallowing, then reversal agent may be administered, and return of adequate spontaneous ventilation is anticipated usually in about 5 to 10 minutes. So now we are entering a transition phase from controlled ventilation to spontaneous ventilation. Initially, the patient's spontaneous ventilation is inadequate, and some supplementary mask ventilation will be needed from us. But mask ventilatory support can gradually be diminished as spontaneous ventilations get stronger. Again, remember suction of oral secretions which have accumulated in the oral airway in response to the metal instruments in the mouth, so suction before you ventilate. Put on an oxygen face mask, transfer the patient over to the stretcher, and make preparations for leaving the room. If the patient has been unstable or has significant cardiovascular or respiratory disease, you will want to monitor the patient in transfer. But this is not always necessary. If the patient is robust and otherwise healthy, there may not be a need for monitoring during transfer. The majority of patients for this procedure are actually female, and they may have a tendency to post-operative nausea and vomiting, so for this reason, Zofran 4 mg is administered about 20 minutes from the end of the procedure. This has been a necessarily brief and fairly succinct consideration of the practical conduct of anesthesia for the laser treatment of tracheal stenosis. Of course, some important aspects have been left out, and if you wish to pursue this subject further, refer to my longer, more detailed video on the same subject. Thank you for listening to my talk.